the patient has an antenatal hydronephrosis detected at 20 weeks or 24 weeks or 28 weeks, whatever be it, you have to repeat it at 32 weeks. And if the previous anteroposterior diameter was more than 7 mm, it is very important to remember this. Okay, so your next thing will be repeat an ultrasound, go for an antenatal counseling, because you need to explain the patient about the possibilities of an antenatal hydronephrosis. There comes the examiner wants you to counsel the patient about the causes of antenatal hydronephrosis, with the most common being a transient, then physiological. 40% can be transient, 15% can be physiological. And since there is hydroureter nephrosis, you can say that 1% chance or 4% chance of a vesicoureteric reflux, 1% chance of a megaureter. So you need to bring about those differential diagnosis. Okay, so you can go through the Oxford. There have mentioned about the differential diagnosis of an antenatal hydronephrosis. You should discuss that with the patient. These are the possibilities, and if diagnosed, then what we are supposed to do it in the postnatal period. You mentioned about an amniotic fluid aspiration and getting a beta 2 microglobulin and all. Those were not those were done previously. There are studies comparing them, but it's not recommended to do it routinely in all the patients. So better to stay away from those things in the viva. That can just take your discussion towards a different direction and take more time. So you need to get a repeat ultrasound. You need to discuss the possibilities with the patient, and you should counsel the patient that this delivery has to be done at an appropriate center. So this is very important. This is all the nice guidelines. Okay, how do you approach an antenatal hydronephrosis? These are the 3 points the examiner will be marking you on. Next is, this is what the examiner wants you when you said you want to know information more about the uh, you want to know more about the severity of the antenatal hydronephrosis. So when you get a patient on antenatal hydronephrosis, you want to know more about the calyceal dilatation, whether the central calyceal dilatation is there or a peripheral dilatation is there, whether parenchymal thickness is normal or not, whether the appearance is normal. What do you mean by appearance? This was what I was asked in the exam. So they want to know whether the parenchyma has cystic appearance. So if there you find that there is cystic appearance in the parenchyma, that is a poor prognosis. That is more severe, not a poor, that is a more severe outcome. Okay, whether the ureter is dilated, whether the bladder is any abnormality, or whether the amniotic fluid is decreased. So all these points you have to see in the antenatal hydronephrosis. So first you need to see the anteroposterior diameter, and once the anteroposterior diameter is more than 7 mm, you get a repeat ultrasound at 32 weeks, counsel the patient. When you review the ultrasound, you review the risk factors for all the abnormalities, whether they are present or not, that will make it a high risk. And then you follow up and counsel for a delivery at a proper center. So once you have done this, then the next question will be when you should get a postnatal ultrasound. We have discussed this in the last scenario itself. The postnatal ultrasound is 1 week and 6 week. They're the two postnatal ultrasound you should get, unless you are suspecting a PUV or a ureterocele where you require to intervene immediately. Unless there is an obstruction, you need to relieve it immediately. So here you don't have to mention about one immediate ultrasound. You can wait. You said it, so I just want to emphasize it again, that you wait for 1 week and 6 weeks. But before that, I told you previously also that whenever you find a scenario on pediatric urology and you have a hydroureteronephrosis and the child is now postnatally presenting to you, antenatal management, you should be very clear. Antenatal hydronephrosis, those 4 points. Now, postnatally, you should always mention, I will clinically assess the child. I will do a clinical assessment. I will start the patient on antibiotic prophylaxis. I will do the renal function assessment, and I will get an imaging now at 1 week. So this carry has to be very, very clear. Uh, I want I will again keep another scenario in the next session. And I want you to keep this in mind that this has to be brought very early in your management, very early in your management. The examiner in pediatric station are waiting to hear this carry. Okay, just remember whenever you get a hydronephrosis in your pediatric station, remember clinical assessment, antibiotic prophylaxis, renal function, and an imaging. Don't directly jump into the imaging, postnatal imaging. Okay, the examiners are very disappointed. And this is the reason why pediatrics is a very low scoring because the candidates they end up forgetting the car. This car you cannot forget. Okay, clinical assessment, antibiotic prophylaxis, renal function, and imaging. Don't directly jump to the postnatal imaging.
Yeah.
Okay, is it okay? Shall I proceed now? So your assessment of this ultrasound was fine. You mentioned all the points very correctly. You mentioned about the from this, based on this, you mentioned that it's a mega ureter. Okay, so your ultrasound was left hydroureteronephrosis. The next thing you said about a MAC3 scan. So it's okay if you want a MAC3 scan based on this, but what the guidelines recommend is when there is a hydroureteronephrosis, okay, first thing is you want to rule out a reflux. Okay, so you say with the MAC3 you want to put a catheter and do it. It's okay, you can justify it. It's absolutely fine. But the guidelines, what do they recommend when there is a hydroureteronephrosis? Your next investigation, because you are suspecting a reflux, you are versus an obstruction. This is your doubt. So first you do a VCUG scan. First, you do a VCUG scan to rule out a reflux. Okay, if there is no reflux, then the next thing is you go for a MAC3 scan. Okay,
I wanted to do down top technique
so that
just
down
to
top,
avoid.
I want to tell you about that also. So suppose there are two scenarios. So one scenario is just a hydronephrosis, okay, where the ureter is not dilated. There is just a hydronephrosis. In that case, it's always better that you go for a top-down approach. You go for a DMSA scan, okay, and then if the DMSA scan is suggestive of a scarring, you go for a VCUG. This is a top-down approach, okay. And when there is a hydroureteronephrosis, it's always better go for a VCUG scan first. If there is, so there are two possibilities. If the VCUG is suggestive of reflux, then go for a DMSA scan. If the VCUG is suggestive of no reflux, go for a MAG3 scan. So there should be no, you can modify it according to you, but the examiner should know that you are very clear about this approach. There's a hydronephrosis. Okay, you are not expecting a reflux, but there is a possibility that certain patient with hydronephrosis also without a ureter dilatation might be having a reflux and causing a scarring. So you first get a DMSA scan. If there is then any positivity, then you go for a VCUG scan. Okay. Otherwise, if there is a ureter is dilated, it's always better to go for a VCUG first. It's always better to go for a bottom top approach. Okay.